I was a typical college kid. I worked hard, but also had fun, and life was normal.
This is Dr. Paul McIntosh, who joined me for today's program via Skype.
I am a third-year neurology resident at Duke University Medical Center.
And Paul has adult-onset Pompe disease, a neurodegenerative condition that affects the skeletal muscles, among other organ systems.
I had a lot of lower back soreness. Right before Christmas break my sophomore year, I got mononucleosis. And after becoming ill, I went to my PCP and he checked basic blood work. I had no symptoms that would ever make me think that I had a progressive degenerative condition of the muscles. With the diagnosis, my life changed in an instant. I went from being a typical pre-med college student to someone with an uncertain and initially terrifying future.
But it was a future that Paul would eventually accept, one he would embrace, and one that would shape his life and his career as a physician.
I still wanted knowledge. I wanted to know more about the disease. I wanted to find hope.
Like Sarah Hinya, who was on our program in the first part of this series, Paul is a tremendous advocate for patients who live with the same condition that affects him, Pompe disease.
However, there's a yearly patient meeting where I get to see friends from all over the country and all over the world, and I don't know, 30.
And he's gotten into some of the research aspects as well at the Duke Lysosomal Storage Disease Treatment Center with Dr. Priya Kishnani.
So I've done research with her as a patient and as a researcher, and
Paul's actually been featured as a case that was published in the Neurology Journal's Pearls and Oysters section.
And one of the things I like most about the article, it says a 21-year-old athletic male.
Something Paul was kind of tickled about.
So in the literature, I'm athletic.
We actually included this reference to the paper for you in our show notes if you want to check it out. Some useful pearls in there too. Anyway, Dr. McIntosh has the unique perspective of being both a patient and a medical provider. And this week on Brainwaves, a podcast about neurology and medicine and all the fascinating science and history that come with it, we're telling his story. For those of you listening to our program for the first time, we share amazing and compelling clinical stories. We contextualize the history of modern medicine and work our way through the differential diagnosis and management strategies for a wide spectrum of neurologic cases. This week on the show, we are continuing on the theme of the patient narrative.
Being diagnosed with the disease is more than just the physical symptoms.
And Paul's symptoms, unlike Sarah Hinya's, who we featured in our previous show, were not symptoms that were socially stigmatizing per se, nor were they symptoms that are classically associated with a learning disability. In fact, they were so mild to Paul that it was utterly shocking to learn that they could be life-threatening. In this week's narrative, what it means to be young, to know deep down that you're healthy and that everything's fine, and then to find yourself face-to-face with a chronic degenerative neurological condition. I'm Jim Siegler. Stay with us. Paul McIntosh was a sophomore in college when he came down with mononucleosis, a viral condition that's popularly referred to as the kissing disease because it spread commonly via saliva.
And after becoming ill, I went to my PCP and he checked basic blood work, including liver function tests, and they were notable for an elevated AST and ALT, like in the mid-200s.
Just to provide some clinical context here, and not to make Paul's story any less serious, but it wouldn't be that unusual to have elevated liver function tests from mono. The Epstein-Barr virus, which causes mono, like other viruses of the herpes family, can cause some liver inflammation. So we shouldn't fault his doctor for not pursuing this aggressively with a more thorough liver evaluation and follow-up blood work.
He had me come back for a lab check several weeks later, and they're still elevated. And then
eventually, Paul sees a GI specialist.
And he was able to diagnose me with celiac disease. Mono triggered that.
Which was a bit of a surprise, actually. Had nothing to do with his back pain or LFT abnormalities. Anyway, back to the LFTs. They never went down. Stayed in the 200s for an entire year.
I had a full liver workup, a liver ultrasound, a liver CT scan, and finally a liver biopsy. And all the results seemed normal.
So he had a serum CK sent.
And that was 1,400.
It turns out, really all those liver function tests he had done, all those abnormal AST and ALT levels, they were all markers of muscle injury, not liver dysfunction.
I was very active.
At the time, Paul was experiencing some kind of constant lower back pain.
I attributed that more to sleeping on a hard bed and actually trained with the boxing team at UNC.
And Paul really had no problem with physical activity or with exercise.
And I had been lifting weights daily for the past 5 years.
Which I think makes this story all the more terrifying.
In hindsight, like running and things like that, maybe I would breathe a little bit heavier than my peers when it came to sprinting or distance running, but there's nothing that I would have ever thought was out of the range of normal.
So a little bit of background here. Pompe disease refers to the rare metabolic disorder.
It's an autosomal recessive condition
caused by a deficiency of alpha-glucosidase, which is required to break down lysosomal glycogen stores. And you can evaluate this with a simple blood test.
It measures the amount of functioning acid alpha-glucosidase in your leukocytes.
More than 300 unique mutations in the alpha-glucosidase gene have been identified with Pompe disease.
Literally hundreds of mutations,
but it can be recognized with a simple newborn screening test of alpha-glucosidase activity, a simple blood test that was added to the list of recommended rare disease screening tests in the United States by the Advisory Committee on Heritable Disorders in Newborns and Children in March of 2015. Unfortunately, newborn screening is still not offered in most U.S. states.
Now it's up to about 10 states.
Which is great, not only because screening will lead to the earlier diagnosis of infantile Pompe disease, with earlier treatment and prolonged life expectancy, but it will also lead to the diagnoses of other forms of Pompe disease that won't manifest for years.
Pompe disease, and that raises its own kind of clinical questions of how to monitor, how often to monitor,
and also when to initiate treatment, which, as we'll discuss, is extraordinarily expensive. So, what is Pompe disease? Also called glycogen storage disease type 2 or acid maltase deficiency, Pompe disease is a fatal metabolic condition if it's left untreated. And Paul knows this. Without normal turnover of glycogen, the excess molecular stores build up in the heart, the skeletal, and the respiratory muscles. And depending on the degree of alpha-glucosidase deficiency, a patient may have one of 3 forms of Pompe disease: classic infantile, non-classic infantile, and late onset.
The way it works in Pompe disease, it's a spectrum. There's the infantile.
In the classic infantile form, which affects about a quarter of patients with the condition, glycogen buildup leads to generalized weakness, hypotonia, difficulty breathing, and hypertrophic cardiomyopathy with heart failure in the first year of life.
It's the kids that you might have learned about in medical school, the floppy baby with the big heart, maybe big tongue.
A chest X-ray is highly suggestive of Pompe disease, with impressive cardiomegaly being observed in nearly every case. More than half the time, the infant will have an enlarged tongue, macroglossia, and difficulty with feeding, which I can tell you as a new parent is a practically universal complaint. But in Pompe disease, first there's a very poor suck and swallow, and second, the feeding duration is often shortened due to early fatigue, and thirdly, the infant will fail to gain weight at a normal rate. Respiratory infections are also common, as is dyspnea and tachypnea, and a serum CK may be elevated to 10 times the upper limit of normal. When the diagnosis is confirmed by a blood spot, the leukocyte alpha-glucosidase activity, experts recommend testing all immediate family members as well in order to provide genetic counseling. This form of the disease, the classic infantile form, has historically been unsurvivable. The non-classic infantile form is distinguished from that classic form by a lower activity of alpha-glucosidase rather than zero activity. And instead of heart failure in the first year of life, children later die of severe respiratory insufficiency in early childhood.
Where their lifespan would be up to about 5 years of age without therapy.
And lastly, in the late onset form, the form that Paul has, patients present with a slow and progressive limb girdle myopathy, difficulty climbing stairs or with running, and later on, they have difficulty performing gross motor tasks with the arms. And there's variable onset of respiratory muscle failure, but this is the most common cause of death. Heart failure is not typical of late onset disease.
And all just depends on the amount of residual enzyme activity you have and some other unknown modifying factors.
When it comes to late onset Pompe disease, Paul thinks of it in 2 ways.
First way is in the outpatient setting where a patient may present with high AST and ALT, hypercikaemia.
Kind of like exactly the way that Paul presented.
Maybe years of progressive weakness.
Keep in mind that the average age of these patients at the time of diagnosis is their mid-30s.
And they really don't see a doctor until they have issues doing things that they used to could do with no issue. Rising from a chair or walking upstairs due to that proximal lower extremity weakness.
As many as 90 to 95% of patients will have this characteristic proximal lower extremity weakness that Dr. McIntosh is describing.
They usually have back pain, like I mentioned, because of weak lumbar paraspinal muscles and excessive fatigue.
So that's one way Dr. McIntosh conceptualizes this condition.
And the other way I like to think of people with late-onset Pompe disease presenting is more in the inpatient side with hypercarbic respiratory failure, and that's due to the diaphragm weakness, which is often in the setting of progressive muscle weakness elsewhere.
Which can go for years without really being noticed by the patient at all, kind of mimicking an atypical GBS patient or a really early myasthenic crisis. Anyway, so Paul was given this diagnosis.
So I still really didn't know what was going on. I appreciated...
He was seen by a neurologist who also was a little uncertain as to what it was that Paul was facing, but he empathized with him. Paul's doctor wanted to know what was going on.
I knew that he cared, and I knew that he was determined to find answers.
At this point, Paul underwent a routine EMG and nerve conduction study.
And, everything initially appeared normal. The nerve conduction study looked great.
That was until he got to Paul's paraspinal muscles.
And there was, what he called at the time myotonic discharges.
Myotonic discharges.
I had no idea what that meant. And I asked him if that could signify a muscle pull or injury, because I was having a lot of back pain, and sometimes during the workouts, I'd feel like I strained my back even more. And he told me no, it wasn't due to a muscle injury, but instead it was due to something inherently wrong with the muscles.
In episode 134 with Dr. Noah Levinson, we talked about myotonic discharges on the EMG, and the differential is not that long. Myotonic dystrophy type 1, proximal myotonic myopathy, aka myotonic dystrophy type 2, hyperkalemic periodic paralysis, myotonia congenita, and paramyotonia congenita. And the one condition where you see electrical myotonia without clinical myotonia, which is how Paul examined, that's Pompe disease. Here's Paul again.
After the EMG nerve conduction study, I went back and saw my doctor in the clinic. And I remember as I checked out of that visit, when I walked up front, gave them my checkout form, they mentioned blood tests for Pompe disease on it. I thought to myself, oh, this sounds exotic. So I Googled it. And after reading a few articles about the disease, I couldn't imagine that I had Pompe disease. I actually knew I didn't have the disease. I was way too healthy to have the disease. A couple weeks later, the neurologist...
Eventually, the blood test comes back, and Paul follows up with his neurologist. And he knows that there's finally an answer to what's been happening to him.
He told me I had late-onset Pompe disease, a progressive and degenerative disease of the muscles. He described the disease to me, resulting in a loss of muscle function. He gave me that...
Paul's neurologist told him about the prognosis, which is variable, and it's highly dependent on the level of enzyme activity. He also gave Paul a lot of resources about available support groups and other outlets that he could look into so that Paul could cope with his new life-changing condition.
And he told me that there's the treatment for late-onset Pompe disease.
An intravenous infusion.
Enzyme replacement therapy.
Lumizyme, or aglucosidase alpha.
And we discussed whether or not I should start that treatment immediately. Given that I was relatively healthy and the quoted yearly cost of the treatment was $300,000 or so.
Which a sane person might say is a ridiculous expense.
A really expensive decision.
But that $300,000 only gets you 1 year's worth of Lumizyme, and Paul gave that a lot of thought. He felt pretty strong, had really no difficulty with daily activities. He was playing sports and he was exercising. Maybe I'll just give it some time, he thought. It wasn't long before Paul thought he should begin treatment. He recalls feeling isolated and alone, and some of this was probably his own doing.
So it was just natural and initially more comfortable to hide. And everyone...
Paul says it took him about a year to come to terms with this new diagnosis. He didn't know who to tell, or how to tell them, or what he should do to improve his health, the foods he should eat.
I continued to exercise, but with less intensity.
Because he had read that some exercise can keep his strength up without causing too much damage to his muscles.
I gave up boxing because it was too taxing on my back. And after 6 months of exercising with no improvement in my strength, I started on the enzyme replacement therapy.
Lumizyme.
It's not perfect in terms of a lot of it goes to the wrong destination. I've had it explained to me, if you put 10 postcards in the mail, only 1 or 2 goes to the right destination.
The intravenous enzyme replacement is actually tagged with a mannose-6-phosphate in order to facilitate entry into the muscle cells so that the glycogen stores can be broken down normally. A lot ends up going to the liver, Paul says, and it's degraded there.
So there's several drug companies, including the current drug company that has the treatment, that are trying to make different versions of the treatment that have more uptake into the muscle cells and therefore are more effective.
But let's talk for a minute about how effective it is. Lumizyme, or aglucosidase alpha, the first-generation enzyme replacement therapy for Pompe disease, had previously been studied in the classic infantile form of Pompe disease. In 1999, 4 infants were studied in an open-label trial. Instead of dying within the expected 6 to 8 months, all patients survived more than 4 years by the time the original report was published. This was followed up by several phase 2 trials of newborns with the infantile form of the disease, which continue to demonstrate efficacy.
I personally know a couple of kids with infantile Pompe disease who are in their early to mid-teens, and with the non-classical version who are in their early to mid-20s.
Which is truly remarkable, considering the fact that the historical life expectancy for those individuals would have been maybe a year for the classic infantile form, 5 years for the non-classic form.
I really like going to the infantile Pompe disease meeting every year just to see them and hang out with them.
Began to receive this life-saving therapy. It's a medicine they still take today that's reversed many of the symptoms of their disease. It's fixed their hearts, it's made them stronger, and now given us time to...
And this is almost exclusively because of enzyme replacement therapy.
You know, their lifespan would have been 1 year or 5 years. They're now living into their teens and 20s. Like, how many medications can really say that? That's amazing.
After having been proven effective in the infantile forms of Pompe disease, enzyme replacement therapy was evaluated in the adult onset form, the form that Paul has, in the first multi-center randomized placebo-controlled trial throughout the US and Europe between 2005 and 2007. In this late-onset treatment study, also referred to as LOTS, patients could only be included if they were 8 years of age or older, they were ambulatory, and they could breathe independently, characteristic of the late-onset phenotype. The study was expected to be positive, so the investigators actually randomized patients in a 2-to-1 ratio of drug to placebo, 2 patients receiving the enzyme for every 1 patient getting placebo, and 90 total patients were enrolled. The primary outcomes were 6-minute walk test and the predicted forced vital capacity, a respiratory assessment. Although the patients were studied for 78 weeks, you can see that within 12 weeks of drug initiation, both measures showed a clinically meaningful improvement with the enzyme replacement therapy. The curves diverged at the very first study visit. By half a year, treated patients were walking 30 meters further on that 6-minute walk test, and they had a 2% improvement in the forced vital capacity. What's more is that the first vital capacity continued to decline over time in the placebo arm, whereas it actually increased and began to plateau in the treatment group. The drug worked. It worked pretty quickly, and the effect was sustained.
Yeah, it definitely slows the progression of the disease. What is really important about this treatment and any kind of treatment is the sooner you get on it, the better you can do, because what muscle you've already lost, you can't get back.
And for this reason, Dr. McIntosh is a huge advocate for the early diagnosis and early treatment of these patients, especially when they're beginning to show signs of disability.
So before there was enzyme replacement therapy, the only treatments were really diet and exercise. Diet being a lower carb diet, less carbs, less glucose you take in.
Less glucose means less glycogen, which means less muscle toxicity and better motor function.
Damage. So I eat a lower carb diet. I don't go crazy, I don't carb count, but I definitely have a higher intake of protein and fats, and that is recommended for people with Pompe disease.
Then, regarding exercise, is exercise good or could it be harmful? In another neurodegenerative condition that we talked about earlier on the podcast, in episode 34, the multidisciplinary care of patients with ALS also involves some degree of exercise and moderation.
Is they ask about exercise and physical therapy and what should they be doing.
We're going to start off on the bike.
Too little, and you run the risk of perpetuating the atrophy and eventually developing contractures.
If you don't exercise at all, you'll get disuse atrophy, you'll lose muscle, you'll become weaker.
Too much, and you break down viable muscle without the opportunity for recovery.
So kind of a submaximal, lower weight, more repetition kind of exercise programs are recommended and have been looked at in some clinical trials as well.
And that's exactly the recommendation of the American Association of Neuromuscular and Electrodiagnostic Medicine, submaximal aerobic exercise. The thought being here that exercise of mild to moderate intensity can improve clearance of glycogen stores, and it can increase muscle strength, although hard science to really support this recommendation is limited. For the past several years, Paul's been fighting his condition, both on behalf of himself and for the Pompe community, which means he had come to accept the diagnosis and eventually had to share it with others around him.
I decided to go public with my condition as a patient presentation to my medical school class.
He was in his brain and behavior block of the preclinical years.
They knew a patient was going to come talk about muscular dystrophy.
But only a few of his closest friends knew it was actually Paul who would be speaking that day. And he used this opportunity not only to educate his classmates about the pathophysiology of the disease and the treatment, as we've discussed today, but also to recruit his colleagues and his medical school for a fundraising opportunity to support patients with Pompe disease.
So in March of 2015, I ran a local marathon here in North Carolina with all my fundraising efforts benefiting the United Pompe Foundation, which is an organization that helps patients cover expenses or travel to conferences and things like that. And with the overwhelming support of many people, I not only finished the marathon, but also surpassed my fundraising goal and raised over $14,000.
Which went to support patients and their caregivers. And Paul thinks of this as one of the most incredible and emotionally rewarding experiences he's had since he was originally diagnosed.
My motivation was that I was not running for myself, I was running for those who can't. So there's always that.
As we're wrapping up this week's program and wrapping up Paul's narrative, I want to circle back to the beginning of his story, when the first thing that Paul remembers was the back pain.
I had constant lower back soreness, woke up with it in the morning, went to bed with it at night.
It was something that didn't really bother him that much at the time. Remember, it was something he had attributed to exercise, nothing ominous at all. But after he was diagnosed, Paul's perception of his back pain, it changed.
It was just always there and always a reminder that I had late-onset Pompe disease.
Now, back pain was a symptom he could no longer ignore. It had become kind of a clinical biomarker to Paul. And with treatment, it was one that he had learned to follow to gauge his response to enzyme replacement therapy.
With kind of diet, exercise, being on the treatment, I rarely ever have back pain anymore, which is phenomenal in my mind.
And not only did this inescapable reminder begin to wash away, other things began to improve too.
In terms of the weakness on exam, I really don't have much, if any, anymore. So I definitely have had improvement.
And whether that was the submaximal exercise, the physical therapy, dietary modifications, or really if it was all just the enzyme replacement therapy, today, Paul's doing well. He's feeling great, and he's not letting his condition get the better of him.
I feel like I improved that. To a degree, some of the symptoms can be stabilized or even slightly reversed if you catch it early enough.
Paul McIntosh. For more information about Pompe disease, take a look at our show notes or check out the resources provided by the United Pompe Foundation at unitedpompe.com. And if you see Paul around, it's his birthday tomorrow, so wish him a good one. This episode of the Brainwaves Podcast was produced by myself, Jim Siegler, with the help of Paul McIntosh. Music for our program today was courtesy of R. Sonor, Franz Dazi, Lee Rosevier, and Scott Holmes. Sound effects were by Mike Koenig and Daniel Simeon. In our next episode, we'll be celebrating Halloween a little bit differently this year in a Frankenstein meets neurology special event. Until then, I'm Jim Siegler for Brainwaves. Thanks for listening.